Thank you, everyone, for joining us today. We are about to get started. My name is Anya Fredrickson, the Director of Training and Impact Strategies at the Peel Center. And I'm just going to briefly go over a little bit about Peel Center, and then we're going to introduce our presenters for today and then get started. The Peel Center serves all 67 counties throughout PA. Um, we are so excited to have you here, but we do have a few ground rules about how to engage with the webinar. We ask that you keep yourself muted unless you are speaking or asking a question, and to primarily ask questions in the chat or ask questions out loud as the presenters open up the floor for discussion. And then we also ask that you refrain from sharing personal identifiable information. We're so glad that you can come here and connect, but we ask that you arrange to talk to a family user specialist or someone else outside of these trainings. The Peel Center is sorry, one second. The mission of the Peel Center is to educate and empower families to ensure that children, youth, and young adults with disabilities and special healthcare needs lead rich, active lives as full members of their schools and communities. And now I'm going to pass it over to my colleague, Christy.
Hi, everyone. Thank you so much for joining us. As Anya said, my name is Christy. I am the Youth Training and Leadership Coordinator here at the Peel Center, working out of Pittsburgh. We are so happy today to be joined by Dr. Victoria Filingeri and Dr. Tal Levin-Decanini. Victoria Filingeri is a senior clinical social worker at the Complex Care Center within the Division of Palliative Medicine and Supportive Care at UPMC Children's Hospital, Pittsburgh. She brings an extensive experience supporting children with complex medical needs and their families through compassionate interdisciplinary care. Dr. Filingeri is also heavily involved in the Leadership Education and Neurodevelopmental and Related Disabilities, or LEND program, where she mentors future professionals and advocates, including myself, for systems level change to better serve children with disabilities and chronic health conditions. And her work blends clinical practice, education, and advocacy to improve outcomes and equity in pediatric care. And we are also joined by Dr. Tal Levin-Decanini, who is a senior advanced practice provider at the Complex Care Center at UPMC Children's Hospital of Pittsburgh. With dual doctoral training in nursing and philosophy, Dr. Levin-Decanini brings a unique blend of clinical expertise, ethical leadership, and compassionate care to her work with children with complex medical needs. She also serves as co-chair of the Ethics Committee and Consult Service. She is also greatly involved in the LEND program, guiding interdisciplinary teams through complex decision-making to ensure patient and family-centered care that's grounded in integrity and respect. So thank you both so much for joining us today.
Absolutely, thank you. I'm just going to share my screen now. Thank you, Christy, for that wonderful introduction. Hi, as mentioned, my name is Dr. Victoria Filingeri, and I have Dr. Tal Levin-Decanini on the call with us as well, who will be presenting alongside me. And we are going to talk about navigating the care of a child and youth with special health needs. So disclosures is that nothing, we have nothing to disclose at this time. Objectives for the presentation. We're defining the population of children and youth with special health needs. We're also going to talk about understanding caregiver views on the healthcare system, tools for navigating the healthcare system, and emergency planning and preparedness considerations. So how are children and youth with special health care needs defined?
Okay, so I'm going to do the first set of slides. Yeah, my name is Tal Levin-Decanini. It's my pleasure to be here with you all. And I will say at the outset, a lot of the slides that I'm using, I actually use when I present this information to medical providers. And the reason I'm also sharing this with you all who, have lived experience caring for children with special healthcare needs is really sort of to set the table for what your medical providers know or maybe don't know and how they think about this, and to maybe set some sort of common language. There's a lot of terminology that is used, and I think sometimes the definitions of those terms are unclear, or you think it means something and people are using it in a different way, including the idea of child health. And you would think that child health is not really something that is unclear, but there's definitions of child health that vary widely. So one of the ones that we've been using for 20 plus years now is from the National Research Council Institute of Medicine report. And it really tried to pivot the idea of looking at health as not just based on medical things. So really thinking about, what do kids need to develop and realize their potential? What do they need to satisfy their basic needs? And then how do we support families in helping their children then develop the capacities that then allow them to interact successfully with their environments, and thinking about environments largely not as just within like the medical environment, but also their physical environment, such as the buildings that they go into, the playgrounds that they play in, their social environments. So things like school and social opportunities. And, again, thinking about the biological underpinnings or the medical underpinnings that relate to health as well. So really trying to contextualize health outside of just a pure medical space. Next slide, please. And similarly with disability, the way we talk about disability is changing, I think, in a good way. So now we more often think about disability as something that exists along a continuum, and it can vary for all of us across ages and across multiple domains, but specifically for childhood disability, that this is something that relates not just to medical diagnosis, but to the environment that we're all in. So it's really thinking about, how does the environment affect someone's ability to engage with the rest of the world? So things like sloping curves to enable people that use a wheelchair to cross the street, right? It includes things like, how ADA compliant is a school building? Is there a bathroom that someone can take their child and change them in safely? So taking the idea of disability outside of just medical diagnosis and really putting it into the larger world around them. Next slide, please. So this is a statistic that is a few years old now, but using a very broad category for disability, there's probably now around 16 million children in the US that meet some criteria for disability. So this is a fair amount of our population. Next slide, please. But when we think about disability categories, and this is often where the acronyms can get confusing, especially if you're looking into research, it can become a little bit like an alphabet soup. There's this larger category of children with special healthcare needs. There's a subcategory of children with significant disabilities. And under that is another subcategory, which is children with medical complexity. So the complex care clinic at Children's, where both Vicki and I work, is specifically focused on the care of children with medical complexity. So that involves children with technology dependence of some kind, such as a tracheostomy to support respiratory function, or a G-tube to support nutrition. So that's often when we think about children with really significant disability, they're lumped into this children with medical complexity piece. However, the other two categories can be a little bit more difficult to understand. So children with special healthcare needs includes the other two subcategories, but also would include a child who's receiving physical therapy or occupational therapy or speech therapy. a child with significant disabilities would also be a child who receives those therapies, but then also has other medical conditions that are affecting their function. So that's sort of in between what we think about, like, in terms of like children with technology dependence, and then children who maybe are utilizing therapies for a limited period of time. So there's this broad range of disability categories, and the research that's done into the care of these children sometimes hones in on one of these categories and sometimes lumps all the kids into one larger group. And that can sometimes make parsing the information that we have a little bit tricky. Next slide, please. And the other thing that we talk about, which will probably be familiar to many of you, is the medical model versus the social model of disability. So previously, a few slides back, when I talked about the definition of disability and the definition of child health, this is really thinking about a social model, right, which is more inclusive, I think more thoughtful to the lived experience of children and families. But the medical model is still very prevalent and often the way that a lot of medical providers think about disability. So the medical model, the disability purely sort of exists in the range of biology, and it's seen as a pathological impairment, which is not great wording, right? Requiring medical intervention and treatment. The social model, again, puts disability outside of this medical model and really talks about the interaction that people have with their social and environmental worlds. So what is making things challenging for that individual, and acknowledging that this can be different in different contexts, right? And that this is different for different families based on whether they're rural or urban, based on whether, even if they're urban in a state with strong healthcare supports, or they live in a state with less healthcare supports. And really the social model is trying to shift away from focusing solely on a diagnostic piece and thinking about environmental social barriers and challenges. Next slide, please. Okay. There's been a lot of research recently about trying to understand caregiver views on the healthcare system, and I'm going to give a brief overview of that. And this is also with the caveat that you would think people have been doing this for a very long time. I think people have been thoughtful about this, but haven't been systematically researching it. And one of the reasons that people are looking into this more is that it's becoming very clear that the lived experience of families versus the experience of medical professionals don't always align. And there's a gap in knowledge and understanding there that's affecting the care of our patients. The next slide, please. So there's a paper done by one of our colleagues at Children's in 2022, where they did interviews with families, and they asked caregivers what those clinicians who seem to be invested in their child, what characteristics they have or what they want them to have. And I don't think this list will be surprising to anyone, right? So caregivers say that they want someone who sees their child and themselves as individuals. They want to have both the verbal and non-verbal cues that demonstrate that that person actually cares about their child and the family, and also respects their input on their child's care. And they want caregivers who are thoughtful about questions that are being raised and take concerns seriously, and really approach medical decision-making as a shared responsibility, as opposed to something top-down that the provider says they need to do without family input. And perhaps most importantly, and honestly one of the most challenging things for medical system, is that they want providers who spend time with them, who are able to take the time and sit down and talk to them. Next slide, please. And we also know from similar studies that parents of children with complex medical conditions are faced with making many medical decisions for their children, often without a lot of input from their teams, and that families become their kids' nurse, therapist, nutritionist, physician, teacher, all of these things in order to care for their child without having all the training to do so. And so you're not just a parent, but then you have all these other jobs that come along with it. And sometimes when you are able to get the input and advice from clinicians, it doesn't really match with your lived experience. And there have been studies that show this for a very long time. Some of the earliest that actually came from the 2010s, which showed that, as you may already know, that families often perceive that clinicians undervalue their child's quality of life. And then a more recent study showed that this is actually a fundamental difference between families and medical providers, in which medical providers tend to view the quality of life of children with complex needs to be lesser than the families. Next slide, please. So people are now looking into why, like what is driving this? In this paper by Ames that came out about a year and a half ago, they did interviews with 30 families, and they divided what the information that they obtained from those interviews into drivers and manifestations. So what are the drivers of these differences in quality of life assessment? So the first one is just a lack of clinician knowledge. The second is clinical apathy, so a sense that providers actually don't take the time to learn what their patients and families' lived experiences are like and have an understanding of how they view quality of life. And the third is just clinical assumptions. So if you are someone, for example, if you're a physician that works primarily in an ICU setting, when you see patients, they're often at their sickest. So that is your lived experience of that condition. If you are a physician or a medical provider that works primarily in an outpatient setting, you'd be seeing those same children in a very different context, right? And so your clinical assumptions are going to vary based on the environment in which you practice. And then how does this manifest? So families feel like what this difference in terms of quality of life assessment manifests like are limited access to care, and that the care that you do get seems to be substandard. And a lot of families felt like medical providers dehumanize their children because they see them as a list of diagnoses rather than a whole child who's part of a family system. Next slide, please. So these few slides just have quotes from the paper illustrating some of these. And I can read parts of them to you, but you can certainly read them on your own or refer to them later. When I have given this talk before to other family groups, this seems to really resonate. And in my own work with families over the last 10 years or so at Children's, this is not uncommon to hear families say this. Basically to feel like, some providers just don't feel comfortable taking care of kids with disabilities. They'd rather take care of a patient that didn't have a severe or special need. Or maybe they don't think that certain things should be offered in care. So for substandard care, this was a family whose child had a cancer diagnosis. And they felt like when they were talking about treatment options, because of the child's underlying diagnosis, maybe the family wouldn't even want to treat the cancer because it's not like a quote unquote typical child. Next slide, please. And then again, clinical assumptions. So again, a lot of this is based on perception of disability or perception of a certain diagnosis in a clinical context rather than the understanding that these kids have lives outside of the hospital setting where providers are working. So I really like the quote at the bottom because they talk about a small piece of that person's life. They only see them when they're in the hospital or they're at their sickest, or only for an appointment, maybe 30 minutes every 3 to 6 months. And they don't have a positive impression of disabilities or medical needs. And I think having worked in the medical system now for a long time, this one really resonates with me when I talk to other medical providers, because I think we do not do a very good job of training people to ask the questions that they would need to ask to understand what these kids' lives are like outside of the medical setting in which we see them. Next slide, please. And this is more about clinical assumptions. And there is a lot of ableism within medicine, and families pick up on it very quickly. And this is very hurtful to families, right? And so we recognize this, and I'm glad that people are actually studying this directly now, and it's being published in large journals that are widely read. And I think we're working hard to change these perceptions. But I think a lot of families are still dealing with this when they bring their children in for care. Next slide, please. And this makes obtaining care very challenging, right? There's been a shift recently to think about family-centered care and shared decision-making. And what this really means is including families and how decisions are made, and offering families options instead of medical providers telling them exactly what to do. But again, this can be challenging if you're working with a provider who does not feel like offering certain options because they don't think it would be important for that child's quality of life, right? But what we know from families is they really want to be involved in medical decision making, and they prefer a collaborative approach. And most families are not looking for this more paternalistic top-down approach to care. Next slide, please. But again, as I talked about in the previous slides, this discrepancy in understanding quality of life leads to attention and can often lead to mistrust between families and providers, where sometimes families don't feel comfortable obtaining care, or they feel they're going to go into a visit and just be dismissed. Or sometimes what I hear from families is, we drove 3 hours for a 5-minute appointment just to get like a piece of paper signed. So this continues to be an area where we are not meeting the needs of our families system-wide. And I think given advancements in technology and in medicine, the way things are going, this is continued to be a challenge, right? So as future outcomes and risks are raised, we're really going to need to think about how that perception of quality of life influences medical decision-making, and be very clear-eyed about it from the provider side. Next slide, please. So the take-home points for this part of our talk today are that parents are in a uniquely difficult situation. As you know, there's a lot of data that shows the emotional challenges related to caregiving. I didn't talk about the economic challenges, but there are actually studies that show how financially destabilizing sometimes care for a child with special health care needs can be, looking at parents needing to take time off work or leave their jobs entirely in order to provide care if they cannot get home nursing or school supports that they need. There's clearly an empathy gap, where families feel that they and their children are discriminated against due to perceptions on disability. And that when we operate under the wrong assumptions, we are providing poor care. And the hope is that as we switch to more family-centered models, there's a better match between a family's goal and medical recommendations. And the way we do this is really by centering on what the family's perception of quality of life is and what their goals are with the medical care that we're providing. And this also needs to be informed by the larger context in which care exists. So this is not just thinking about short-term, they're in the PICU right now, or in an outpatient setting, what do we need to do for the next 3 to 6 months, but really thinking about what is their access to supports in the community like? What are their social opportunities like? What is going on at school? What is going on in terms of access to things like playgrounds or family supports? So really arguing that we need to, as medical providers, take our perspective out of the clinic and more into the environment.
Thank you, Tal. And so moving in, following that discussion regarding quality of life and how caregivers perceive the healthcare system and their interaction with providers, we also want to provide tools for navigating the healthcare system and navigating the conversations with providers that come up. And so we want to emphasize that caregivers are experts and provide unique perspectives on their child's quality of life. And there's a huge responsibility that is on the healthcare providers to do better, to be able to better understand their patients, their quality of life, and step away from biases and their thinking in the medical model, right? Really trying to understand their patients and the children from a social model, really encapsulating that their identity is outside of their disability. And so while this responsibility falls on the medical team, what can sometimes be really helpful for caregivers is to provide information regarding your child's likes and dislikes, what makes them smile and what makes them become frustrated, having better understanding of like what they are at home, what they're like at home, what are some of the activities they like to engage in, who are their friends, what do they like to do, is really helpful in order to kind of be able to better understand their quality of life outside of the medical setting, because it's a very quick visit that's really difficult to try to have conversations about what's going on outside of that unique time frame. Similarly, it would also be really helpful to share information about their unique and varying abilities. What are some of the things that they're able to do that we haven't been able to see in the medical setting? Sometimes sharing an important story or photo can help to better understand your child. I recently heard about a family who was very frustrated with their medical team on the inpatient side and felt that they really weren't aligned with how the medical team was viewing their child's ability and how the family saw their child. And so to better provide a picture of what their child is able to do, they created a PowerPoint, including photos and videos that they had taken at home to present to their care team. And that really helped to be able to kind of allow the medical team to better understand them and what is their life outside of this setting. Similarly, we also, it would also be good to define for the medical team what a good life is for the child. What are some of the things that you would want for your child? We also ask that parents be transparent with medical providers when feeling ignored or when, your perspectives are misaligned. Sometimes it at times can be really difficult to have those conversations, but medical providers welcome those conversations in order to be able to better care for you and your child and ensure that you both have perspectives that are being integrated into the treatment plan. And also request clarification and raise concerns as they occur. Open and honest communication is always helpful. What's also really helpful is in navigating the healthcare system and really trying to organize kind of like who is considered your child's care team. It's good to identify the providers that are involved in your child's care to be able to kind of understand who you need to go to for certain things. And so we ask that, a primary care provider be identified, and, subspecialty providers are often involved in a lot of these children's medical care. Therapists are also part of the care team. This can include physical therapists, occupational therapists, speech and language pathologists, vision, behavioral, the list goes on. Social workers, case managers, and care coordinators. They're all involved in trying to support your child, and those supports are available as well. It's wonderful also to integrate community supports into the care team, as they also provide care to the child in the community. And so this can include schools, nursing, and home health agencies, and behavioral health providers. We also encourage communication between all these care providers to ensure continuity of care. And you can also encourage them to have direct communication with one another whenever possible. This can be done through releases of information and providing and exchanging information of contacts. This helps to also kind of like because a child sometimes, like let's say their medical care is not just seen in the medical setting, it's also seen at home and in the community and at school. When you do have community care supports or providers that are out there also working on similar things. So if a lot of the issues that come up are often with school. And so if there is a challenge with like the child's, let's say medication administration at school, it would be helpful for the school to be able to talk directly to the medical team to obtain information and be able to better support the child out in the community. So having those communications and direct collaboration is helpful. So care coordination is specifically very important and in children with special healthcare needs as they require multiple services across various settings. Often what families experience are a lack of coordination, which can lead to missed appointments because of the fact that there's multiple appointments that are being scheduled with multiple services. Sometimes medications are being prescribed and not communicated or was communicated during an appointment but missed because of the time limitations. And sometimes this can also lead into gaps of care. And so what's really helpful is having a centralized approach to improve outcomes and to reduce stress for the family. And so a medical home is something that is recommended. So ensuring that you have a primary care provider for your child that understands the child's medical conditions, their abilities, and that they're comfortable in providing the care and also comfortable with being a central point for care plans, for communications with community providers, for referrals and medical records. It's also helpful to create and maintain a comprehensive care plan to keep updated medical information, their diagnoses, their treatment plans and goals. This can include, the therapies that they're also engaged in, medications, medical providers and their contact information in the event of an emergency, and advanced care plans and educational plans. We also, again, encourage collaboration and open communication to share information with all providers whenever you feel comfortable and to hold team meetings when you do feel like there are parts of the care that are misaligned. And there's also the support of care coordinators and case managers that are able to also assist with managing appointments, with scheduling appointments, being able to identify resources to kind of help with coordinating healthcare. These services are available through hospitals, insurance plans, community and state programs. And something that I didn't mention here is also kind of, and it's a plug for social work, but social workers are also able to assist with like looking at the barriers and the challenges that might make it difficult to come to a medical appointments or identifying medical homes. And they can also assist with resources to help with coordinating care. What's also really important is to build a community and supportive networks. So we encourage families often to connect with other families, support groups and community programs, and advocacy organizations that exist at local and national levels. At the local level, we know PL is a wonderful resource. Family centers. There's also in the state of Pennsylvania, pediatric complex care resource centers that also are very helpful with identifying resources for medically complex children in the community. At a national level, you have family voices, parent training and information centers, and centers for independent living. It's also good to identify community and state and federal programs. Some of these programs can be very helpful with providing support, but also funding to allow your child to live out in the community. And this can include behavioral health services. It can include intellectual disability and autism supports, coordinations, Medicaid waivers, and SSI. And local nonprofit organizations are also available to provide some more immediate support too, to kind of connect to those larger programs. So advocacy and empowerment is very important, and I'm sure all of you have engaged in advocacy in one way or another with the multiple systems that are involved in your child's care. And so some of the recommendations that we have are to remain informed about your individual and child's rights. It's always good to be informed so that that can help you navigate the systems better. But if you do need support, there are advocacy training programs and educational events that can help to aid in enhancing communication skills. The Peel Center holds certain at certain times in the year events around advocacy training, and the University of Pittsburgh Leadership, Education, and Neurodevelopmental Disabilities program has a PIT Academy, Advocacy Academy called the LPAA, which is also held about 2 times a year. And I have a flyer for that for additional information, but that is really helpful to be able to assist with enhancing the advocacy skills needed to navigate multiple systems. It's also helpful, if developmentally appropriate, to engage your child or your youth in advocacy and building and helping them build those skills to be able to self-advocate, especially in the medical system and when navigating school. If it is appropriate, it would be helpful to have them attend to be able to learn about what are their rights, what are some of the things that would be helpful for them, and have them and allow them to have a voice. It's also good to build collaboration with community organizations to remain informed about the challenges that the population is facing and what can be done. And it's also good to speak up and inform politicians and larger institutions and systems of the challenges and policies that impact this population and to advocate for change. So as mentioned, some advocacy resources, you can definitely go to the Peel Center events page for online training opportunities that they offer through sessions. And as I mentioned, the LEND has a leadership advocacy academy that they run, and you can contact Dory Ortman for that. So something else that we wanted to talk about is emergency planning and preparedness, which is something that in the medical setting, I think we need to do a better job at. It's not something that is actively brought up, but it is something of importance that I think is helpful when navigating your child's health outside of the healthcare system, but also within the healthcare system, because much of, I think, the most recent power outages that Pittsburgh had experienced had caused a lot of challenges for a lot of our families that we see within our population that have medically complex children that are dependent on electricity. And they had to figure out how to gain access to electricity, right, without having to come into the hospital. So emergency planning is very important, and we wanted to talk about that today. So there are wonderful resources out there. The first step that is identified is kind of like be informed and have a plan. So you definitely want to be able to introduce your child and become familiar with local first responders. That could be just by going up to them, providing them information on your child's needed supports during an emergency. And if there are advanced care plans, we want to be able to share that with them. You also want to know and identify and sign up for emergency alerts and warnings. FEMA has a wonderful website where you can do that to know what alerts and warnings are in your area regarding weather. It's also good to contact local emergency medical services and emergency management offices in your area to inform them about your child's medical needs, special equipment needs that they have, and whether electricity is needed for life-sustaining activities. It's also good to ask them about transportation available in an emergency. And if, there are shelter options that would support your child's need if that is something that comes up. The CDC has some wonderful information around that for children and youth with special healthcare needs in the events of emergencies. It's also good to make a plan as a second step, create an emergency plan, make a to-go bag. You want to include your child's medical diagnoses, information on their medical supplies, medical contacts, comfort items, copies of records. For copies of records recommended, their identification, their social security cards, or birth certificates. Include any documentation of identity that might be helpful. You want to also include backup power and medical equipment plan. You want to explore local resources for generators if electricity is needed during a power outage. Another organization, Chiva, offers funding, which may be good if you are looking to purchase a generator, but it's too expensive. Local community providers sometimes have funding opportunities to be able to supply funding to be able to purchase that. You also want to safely store the plan in one location with the critical documents and valuables that you're taking with you. It's also good to understand the difference between seeking shelter and shelter in place, especially during emergencies. And if you're also trying to navigate that with trying to transition with a child with a medically complex condition and all of the equipment that they have. So it's good to have plans for both and what to do and to practice that plan and become familiar with the evacuation route that you're choosing. It's something that's not often talked about is to include a list of local pharmacies and hospitals near you, especially if you are traveling out of state and there is an emergency that comes up. It's always good to have that information readily available. Build the kit. So you want to consider what your child and family needs are to build your basic disaster supplies. Ready.gov has a wonderful kit kind of outline that you can go off of. But you want to include information on the date and list of your child's medications. Consider your dietary medication and medical equipment needs for your child and how much electricity and access to power and supplies that they'll need. You want to safeguard critical documents and valuables that we mentioned earlier, and have that readily available in a location that you will be able to easily pick up and go. And that kind of ended the presentation of our recommendations. If there's any questions, we're happy to take them.
Hi, Victoria. This is Jackie White, and I had a question. This has been really great, and I appreciate it. But one of the things that you recommended was if, some kind of concern would arise, something like holding a team meeting might be something to do. Do you have recommendations on how to do that? I'm just asking because sometimes it's so hard to even get in with your clinic or talk to your provider or talk to anybody. Like, what would your recommendation be to do that?
Yeah, absolutely. That's a wonderful question, and thank you for asking. So it is challenging, as you mentioned, to get in with a provider. If there are multiple medical specialties that are needed to have this larger conversation, we do recommend that you request a care conference. And what that does is help to bring multiple providers to the table to have a larger conversation of the concern and allow the parents to also be able to talk and express the challenges that they've been experiencing. That does take some time to schedule, as you can imagine, because there's multiple schedules that you're working with. but it has been really helpful, and it's a tool that's often utilized in the inpatient setting, so when your child is admitted in the hospital, but it is something that can also be done in the outpatient setting, but is a little bit more harder to do, but we're happy to do that. So just talk to your medical provider about your concerns and request to have a care conference, and that is something that they can try to work on helping to coordinate. You can also ask for social workers or care managers that are on your team. And if you haven't been introduced to them, you can always call and ask to see if their office has one, and they would be able to help with coordinating that and being able to set that up.